So we'll give everyone a few minutes. So Julie isn't going to be able to show up or isn't available today, and Caitlin has a conflicting meeting for a couple of these months. So you're stuck with Donna and I running the ship for at least a little bit.
Good morning, everybody.
Yep. Hello.
Hi, Brian.
Yes, so I think we'll give folks 2 more minutes. 9:05.
This is the most awkward of awkwards when we're waiting for people and everybody's just kind of looking at each other like, hey.
It's your favorite. I know.
Yeah, no, not so much. Good morning, everybody.
Good morning.
Good morning. Good morning. I wish everybody had a delicious burrito like me.
Oh man.
So do we.
Maybe
Me
when we go
too.
back, maybe when we go back to having them all together, then I can provide.
I'm in.
Thanks.
So if it's going to be a couple more minutes, I just want to mention, and treatment is on our agenda. I attended this Zoom session yesterday. It was put on by Universal Health Services, and it had some really excellent information about, it was mostly geared to treatment centers. So I'll forward the slideshow, because all of the slides are credited at the bottom, so it's not like I'm stealing that person's info. But I think it's really good information. It was about, the title of it is about how the COVID-19 pandemic has increased stress and thus created more substance use. So maybe you'll get something out of that.
You'll send that to me, Lorraine. I'll attach it to the minutes.
Okay.
I think we can get started, right? So with that, as people are coming on, Julie is unable to make it today, and Caitlin is running late with a conflicting meeting, so I think she'll be here around 10:30 or so. So with that, they asked if Donda, Lloyd, and myself would be able to lead the ship for the first part of this. Hope everyone's okay with that. Marching us along. With that, Lloyd, do you want to do the introduction stuff?
No, if you would go ahead and do it, I'd appreciate it.
Okay. Donna, do you just want to go through and kind of have folks introduce themselves? And
Do you want to go ahead and start us, Ryan?
Yeah, I'm Ryan Templeton, representative for the Office of Behavioral Health. I also serve as liaison between OBH and the council.
Okay. Daryl?
Good morning, Daryl Brown. I've missed you guys. It's been a couple of months. I've been doing some training, and now I'm able to enjoy. I've procured a position at Sobriety House as intake coordinator. I am a co-chair of the recovery committee, and I just celebrated on Tuesday 4 years of recovery. So I'm really excited. It's been a great week, and it's really good to be back. It's good to see you all, and I'm glad that you're all doing well. Thank you.
Thanks, Daryl. Lorraine?
I'm sorry, did you say Laura?
Lorraine.
Oh, well, I'll go.
Oh,
Lorraine,
go for it, Laura.
since I'm already talking. Laura Dykes, BH Director at Colorado Culture for the Homeless. And I think on the treatment committee. And hi, everybody.
Let's turn
Sorry
right.
about that, Rhonda. Is it okay if I go?
Yep.
I was trying to download those slides I mentioned, so I was muted and in the middle of something else. I apologize. But yeah, Lorraine Hall, I'm co-chair for Lifeline Secular Recovery. And you know, there's just a lot going on. We have really, our Zoom meetings are Zooming because people find that it's better to not get dressed up and have transportation to get to a support meeting. So that's a good thing.
Okay, Natalie.
Good morning, everyone. I'm Natalie Brown with Summit Stone Health Partners, Program Manager for Community-Based Recovery Services programs, including Clubhouse, Supported Employment, and Peer Specialists. Nice to see you all.
Thank you. Brian?
Morning, everybody. Brian Laney with Step 7 Ministries. I also have a seat on the Behavioral Health Planning and Advisory Council for Colorado, and happy to be here. Glad everybody is doing good, healthy, and safe.
Thank you. Marcella?
Good morning, everybody. I'm Marcella Pies with Idea Forum Incorporated. I am a family member. I work with the treatment committee. And I'm glad that, like everybody else, that, wow, it's great to see all the faces because that means we're all doing well. And here we are. And we're ending at 2020, and I look forward to 2021.
Definitely. Okay, Margie.
Hi, I'm Margie Grimsley with the Colorado Federation of Families for Children's Mental Health, and I guess a membership and prevention committee, and just hope everyone had a good quiet Thanksgiving, and that we all make it till 2021. So,
Thank you. Aaliyah?
Hi, everybody. Aaliyah Andrews. I am your TA for recovery from the Office of Behavioral Health.
Victoria?
Dr. Vicki Ellen Sanchez with the Colorado Springs Fire Department. I'm the navigation supervisor for our CARES programs and now homeschool teacher too. So added a lot.
Jacob?
Morning, everyone. Jacob Marion, personal long-term recovery. I'm also with Step Denver, it's the Sober Home Program Manager. I'm on the recovery committee, and glad to see everyone this morning.
Good to see you. Rachel?
Good morning, everyone. I'm Rachel Hord with the Division of Vocational Rehab, Behavioral Health Supported Employment Trainer Coordinator. Good to see everyone.
Thank you. Lloyd?
Good morning, Lloyd Moore, Person in Recovery. I'm on the I'm chair of the membership committee. I'm on the recovery committee, and I'm also associated with the Last House on the Block.
Bonnie?
Good morning, everyone. This is Bonnie Holiday with Office of Behavioral Health. I'm your prevention TA, and I hope everyone is having a great week.
And James?
Morning, everybody. I'm James Gannon. I'm a man in active and sustained recovery. I'm with Advocates for Recovery Colorado, and I sit on the recovery committee.
Thank you. Crystal, can I grab you now?
Hi, this is Crystal Ellis with Sobriety House. I am on the treatment committee. Good morning.
Good morning. Karen?
Hi, I'm Karen Irick. I'm Chief Clinical Officer with Crossroads Turning Points, and I'm glad to be here. I was out with COVID for a couple weeks, and so it's good to be back at work doing something, actually.
Welcome back.
Thank you.
And Ty?
Good morning, everyone. My name is Ty Smith. I'm a peer. I'm also your representative to the MHDC JS, mental health. Can't remember what the D stands for. Sorry, it takes me a while. Give me 1 second. I'm sorry. Mental health disorders and the criminal and juvenile justice system. Thank you.
All right, is there anybody I missed? All right, sounds like we're good to go, Ryan.
Yep, so Mark Conajani, our OBH's adult programs director, he's going to be joining at 9:30 to pick up on the discussion on treatment and those recommendations then. So in the meantime, the next step is the approval of the November meeting minutes. They were sent out via Donda's email, right, with the, I guess I have.
On November 25th.
Yeah, I did. I thought they were fine. I make a motion to approve.
I can second that.
Lorraine
Thanks,
and Natalie.
Rhonda.
Thank you.
So with that so we'll go backwards. Anyone opposed to the motion and second? Anyone choosing to abstain?
Ty, this is Ty. I wasn't here for the whole meeting. I'd like to abstain.
Okay, and just to be clear, even if you weren't available for the meeting, you don't have to abstain from voting due to we're approving the minutes. If you agree with how they're written, that's the process, but we'll definitely mark you as one abstaining. And with no other comments or that minutes pass. Thank you. So next on the agenda is continuing the discussion on treatment. So just as a quick recap, last time we went over the presentation from Mark and myself about treatment in Colorado. Right, I think we probably, I guess with that, do you want me to share my screen and we can go over that quickly? Just so we get a refresher. It feels like it's been a little while, even though it's only been a month, but. Donda, can you add me as a co-host? Thank you.
You should be good, Ryan.
Rearrange my computer here. All right, so this is the presentation I was talking about. Can everyone see that okay? The behavioral health treatment in Colorado from November 5th.
Yeah.
All right, so quick overview. We went over the behavioral health treatment structure in Colorado, some of the behavioral health funding, and then treatment recommendations. So with that, it's services are along a continuum, similar continuum for mental health. It's more established for the SUD side, right, because of the ASAM levels of care. So that might be one of those ones that we take a look at, which were part of the recommendations or the ideas for recommendations. We're establishing a clear continuum of services for behavioral health. That is part of Senate Bill 19.222, and those requirements is setting up a true safety net system that we can get there, or we will get there shortly. With that, funding in Colorado, about $1.4 billion to support behavioral health services, distributed to at least 10 state agencies, over 75 programs. So this is, the behavioral health task force in a nutshell, right? Like coming up with how do we get it to make it so it's easier for people to access services, move through services, as well as providers provide services. So it's not so convoluted in a bunch of different departments doing different things, and you have to have multiple contracts with multiple departments and agencies in order to provide potentially the same service. All right, so OBH specifically, about $268 million budget. Majority of that is state appropriated, and with that, the federal block grants, 13 million for mental health and 29 million for SUD. So that's what we're talking about specifically with Bhpac and those recommendations about those $42 million worth of federal funding. With that, the 19 recommendations we put in here, which we won't go over those here, and then we get to treatment recommendations ideas. So with that, right, so Medicaid expansion, including substance use residential and withdrawal management services into the Medicaid's benefit. That comes online in less than a month, right? So January 1, that comes up. I think there's a lot of questions that still need to get answered to that. Right? Like, do we have capacity for it? Like, are we able to spend that? Are we going to be able to spend that money? Do we have providers that can provide? Is there going to be? Yeah, I think there's just a lot of unknowns. I was in a meeting yesterday, even the unknowns about how withdrawal management is going to fit into the more of the treatment. Is that because a lot of people see withdrawal management as being that last stop, right? Like, oh, something happened to someone, so they end up in detox, and then nothing happens from there. They kind of go through the detox and then they get sent back out. Like, how can we better serve people in that time to get them into the treatment system, and what does that look like for the expanded benefit? Which, yeah, I don't have those answers, which maybe that's one of those pieces that we can discuss a little bit further in here about what that actually looks like, getting people into services at the time of need or when they're ready. So it's not, because in the meeting yesterday, we also talked about those folks that are currently sober seeking services, and sometimes it's easier to get services when you're actively using, which is probably not the best way to for a state to like only access to services or treatment services is if you're actively using. But those are just some other things going on, right? So then how to better support integrated services, right? Across, we know that individuals experience both mental health concerns and substance use disorder concerns, right? So, how is integration happening, right? So federally, there's two separate block grants, the mental health block grant and the substance use disorder services block grant, right? In Colorado, there's still, our statutes are broken, or our Colorado laws are broken down into mental health services and substance use disorder services. So how do we, as the actual community and a state, start combining how services are actually being delivered in more of an integrated approach? I think we've been talking about that for quite some time, and then how do we actually get there is really the next piece. These last three, kind of talking about what should Colorado consider as core behavioral health safety net services. So we have safety net providers. You could probably consider crisis services safety net providers. You can consider MSO safety net providers. You could probably consider community mental health center safety net providers. How do we ensure that those, and other service providers that provide safety net services, how do we really standardize what services are being provided and really encouraging people to provide those more high intensity services, and how do you encourage more high intensity services? That really is Senate Bill 19222 in a nutshell, is what our core behavioral health safety net services, clearly coming up with here's the continuum of services, treatment services provided in Colorado, and then setting up a payment model that better supports programs and services that are deemed high intensity, but then it also comes up with, well, what is a high intensity behavioral health treatment provider, right? Is that, and they should get reimbursed at a rate higher if they provide higher intensity services. With that, I think there's a big opportunity for Bhpac to really weigh in on some of that stuff, and what does the treatment system actually, or what should it actually contain? And then the last one on here is, what role should peer specialists play within the treatment system? I mean, we kind of have that kind of as an ongoing thing, right? There's treatment, there's recovery, and then there's the overlap as well. Because really recovery happens everywhere, right? So it's not just, if you're in a recovery service, that's the only place for recovery, like we've talked about previously, right? Treatment is needs to be focused on what recovery and what people's needs are as well once they get in, so they have better access. And then on the front end too with prevention, right? So how can we support folks really across the continuum? Questions about that stuff? What did I miss? What did we?
I have a few questions. This is Ty. My first question is, how is the budget looking compared to previous years, and how is Tabor going to impact it? Are we going to be in dire straits for like the next 5 years? My second question is on the treatment recommendation ideals. Is that related to, like, if there are budget cuts, what we prioritize in saving, or are we? Is there something that we can do that where we recommend what should be saved at all costs? And then my third question is, are you familiar with last year's House bill? I believe it's 1139, Autonomous Peer Run Services. And I believe MHA, Mental Health of Colorado, is going to revitalize that again this year. And that seems like something that this council should weigh in on.
Yep. So yes, we'll work backwards. So yes, 1139 was a peer bill that essentially created a process for approving recovery support service organizations. That is, if they passed an approval process, they would essentially be able to bill Medicaid for the peer or recovery services provided by peers within those approved RSSOs, right? So yes, I've also heard that Mental Health Colorado is going to revive that bill in some way, shape, or form. There was also a sunrise review done by DORA about how peers are credentialed and should be credentialed in Colorado. Currently, they go through this process of going through, I think it's roughly 60 hours of training, and then you get to sit for the IC and RC exam through that COPA manages, right? So that was the process that was reviewed by DORA. The Sunrise report is available on DORA's website. It came out on October 15th. If you're interested, and I can add links to the minutes if we want. The conclusion with that is that Dora did not think that peers should be regulated. There's been some discussions with what does that mean? Does that mean that Dora does not think that they should be the ones regulating peers? Right. So I think that's what is potentially driving the revitalized 1139 bill for mental health Colorado is what, I mean, having standards for peers, I think makes it easier for payers to pay for peer provided services, right? So it's kind of this along the line of, I mean, if there's a standardized credential and if COPA's, the IC and RC credential is good and that's what we want, then great. And I mean, I think that's also an opportunity, Ty, you're right on, is that BPAC should have that opportunity to weigh in about what does peer support services in Colorado, and that those standards look like. Which, yeah, and that will be a bill that comes, I would imagine that will come up pretty early within the session when it starts in January. Questions about that? Yeah, it's kind of a lot of those unknowns right now with, yeah, hearing those things. I haven't seen really clean drafts of anything new. I've just been forwarded like, here, 1139 from last year. Like, yep, we're familiar with that from last year, but I don't know what the new language would potentially look like.
Well, from my understanding, it was wildly successful. It passed unanimously, but was only stopped because it had a fiscal note attached to it, which I think they're still trying to do, but look for funding elsewhere.
Yeah. So, Ty, you're exactly right. I think so during the session is when the COVID hit big time, right? So then there was right. So essentially any bill that had a fiscal note, they said postpone indefinitely, so they didn't pass, right? So it's still one of those things that I think it's going to be interesting this session, starting in January, about what bills with fiscal notes look like because of the budget, right? So state departments, again, were required to make cuts to the budget for fiscal year 22, which the General Assembly kind of goes through the process of approving in this year, right? So with that, they're kind of going to your first question, Ty, is about what does the budget for Colorado look like? I think it was a little bit better than was expected in those forecasts, but now we're at another spike of COVID. So with that, I think there's still massive unknowns about how the economy is going to be affected by rising COVID rates. Don't know what's going to happen with COVID rates after, Thanksgiving and through Christmas, right? So it's honestly, everything I've heard, it's still a massive unknown. As you've probably heard, there was a special session to get money kicked into the system for businesses and whatnot, which I was going to go over in the OBH updates, but it's one of those ones where, yes, there's some things that need to happen that, Colorado's still struggling with the economy. So how does that affect services? But the piece with that is that it's still, we're very dedicated to ensuring that services are still being provided. And that's where I think we can come in with what are those core services that are 100% required. So just as a little bit of background, so the budget cuts for OBH this year related to programs that are not up and running yet, as well as those jail-based services. Because the thought being is that if we cut community-based services, then folks get fast-tracked into the criminal justice system to receive the services that they desperately need. So that was the reason behind cutting like JVVS and offender-based behavioral health services, which were the larger cuts from this year for within OBH's budget. What other questions did I miss from in there or need clarification on?
I guess my concern is, and my biggest concern is around Tabor, and how budget cuts aren't gonna just hit us this year, but have years of impact. And with everything, moving over to a virtual platform, I'm concerned that the brick and mortar facilities, the peer specialist facility, the peer facilities like clubhouses and drop-in centers will be at risk in years to come because there's, like Rod Rushing, who's running a successful clubhouse model, virtual clubhouse model, and having 70 plus meetings a week. So I just want to make sure that we advocate to continue to, support those facilities. And when they can open up again, that we still have, things like clubhouses and drop-in centers and peer programs that aren't virtual for some of our clientele and consumers and peers who prefer not to use the virtual model.
Yeah, Ty, I think you hit on a lot of good points with kind of the struggle kind of across the board with people need interaction, people need in-person services as well, right? So how do we actually get there in the midst of rising COVID cases and a global pandemic, right? So like how can we be safe with still providing services that people need, right? So, I think you're right on with a lot of the questions, and then how does Tabor, the Taxpayer Bill of Rights, and how the state collects fees and taxes, and how that gets parsed out between government or back to tax refunds, right? So there's a lot of these moving pieces that, are essentially massive unknowns that are going to be unknowns for potentially year after year until things even out, right? I don't want to sound like that it's just kind of we're all over the place with the state's economy, but we kind of are, right? Like there's a lot of massive unknowns out there. The piece is that we know that, behavioral health stuff is not going away. Everything that I've seen, COVID and isolation kind of leads to more anxiety and more everything, right? So I think that's, if there is silver lining to this, is that I think people are understanding that there is a major importance related to behavioral health and ensuring that there is an active and robust behavioral health system in Colorado to support people kind of wherever they're at, right? So with that, I think there is hope that with the behavioral task force, the governor's blueprint, the new behavioral health administration, that's also going to be a bill in January, that there are opportunities to weigh in on what the new system is going to look like, or how our current system is going to change into a newer, better system. So with that, I don't think we have the answers right now, but I think it's coming up with the, like, how do we get there? And that's essentially can be the charge of this Bhpac as well. Mark joined with us. Thanks, Mark. Kind of just going over the ideas here from last month, and then kind of coming up with how do we, these were just really designed for the, trying to get conversations started, and then where do we go from here to really start to more concretely formalize what Bhpac wants with their recommendations that go into the block grant application.
Yeah, great. I'm glad to join the conversation. Sorry, I'm not able to be here for the entire meeting today, but kind of really excited to hear what this group recommends and comes up with.
So I pulled this from the meeting minutes. So we talked about essentially or these 5. So that's the bolded and italicized, right? So those ideas, and then we kind of had bullets underneath those. I'll make this bigger. So with that, do we just want to go down the path here, or do we want to really come up with, really this is the opportunity for Bhpac and Bhpac members and guests to really come up with what are there other ideas that we want to really put on paper here and really explore over these next couple months, right? This should never feel like this is the state saying Bhpac shall do this, right? Like that really defeats the whole purpose of having an advisory council. So it seems like I've been doing a whole ton of talking.
Yeah, but Ryan, I think it is also worth pointing out, with Senate Bill, I forgot what it was, but 222, that charges us and Medicaid with really kind of describing what is the safety net system, what are the core services in the safety net system. There's, we have some responsibilities, so we've been working on this information. And so it's a baseline, but we really wanted to be informed by this group. So if there's something in here that's missing, we need to know about it. If there's something in here that needs to be tweaked a little bit, or if there's something in here that you find, geez, I really struggle with this, why is this included? You got to let us know. It doesn't necessarily mean we change anything, but we're not going to change anything if we don't hear from you. So we definitely want some input. You guys are the experts in our communities.
This is Margie Grimsley, and I'm not sure how and when, if this is appropriate time to throw this in, but one of the things that I feel it is so important, and it's something that I've learned through my system of care work over the years, is the need for transition, either a safety plan, a transition plan, whatever people call it, safety crisis plan. But some of these things, when people are discharged from wherever they're leaving from and going to might mean the streets, or it means going to a home back to their family without any adequate supports and services in place. In the system of care world, we really talk about a transition plan. How are we building that? So when you leave one place, it almost begins when you first enter someplace. And then you develop this plan. So when you leave, you really have the core pieces in place that are necessary. So using the children's world again, what school is there, where you're going for your therapy, who you're connecting with. And it's that kind of wraparound plan, I guess, for lack of a better way to describe it. And for knowing people right now, when they go into a facility, it's in a crisis situation, then they leave that facility and there really truly is no concrete planning. And whether you're 12 or you're 50, it seems to be that same scenario of we get you in someplace, you fail, and then where do you go? And I truly believe if we could come up with a policy, a practice, guidelines, criteria that are mandatory when you leave a facility, you're not just said, and we talked about this last month, but I think it's critically important that when we're talking about these pieces, that we see them, how they're connected, number one, but number two, we do not send people away from any place without some place for them to go to. How do they get their meds? How do they make that telephone call for that therapy appointment? Because otherwise, I know somebody today that's being sent home by a cab because he was sent to a facility in Colorado Springs because there was no place available in Denver after having gone to the crisis center. Back to a home that has no more capacity to meet his needs than they did when he went in on Sunday. So I just think it's critically important that transition planning process is not one that it's not just a pretend, it's something that has to be in place before a thoughtful one, a real life one. And I'm sounding passionate because I'm just very frustrated because I don't see that happening right now, and how we can ensure that those things are in place as we're developing these new policies and recommendations. And I'm sorry I went on, and I will mute myself now.
Well, Marjorie, this is Karen Irick.
Okay.
I totally agree with what you're saying. That is of the utmost important for people. Otherwise, it's just almost like a temporary fix, if you will. So thank you for telling us that.
I'd like to mention a couple of things. So thinking about what we had talked about last month and what Margie just said, and Ty even, how we should probably be figuring out how to best phrase or put language into the treatment recommendations that recovery doesn't start after treatment. Recovery is often part of the process. It's complementary to treatment. So recovery doesn't start when treatment ends. So I think we need to remember that and figure that out, whether it's peer services or drop-in and clubhouse services. Those are all complementary to treatment. And this can go across the spectrum, you know, recovery services for children, families, as well as adults and our senior population too. So I think we just need to figure out how to best put that language into our recommendations for treatment as well, whether it's wraparound or safety net services or whatever the case may be. I'm having a hard time putting a thumb on it, but want to get that out there.
Yeah, I agree. I think, you know, following the continuum of care model from high intensity treatment down to maybe more peer related services, but allowing patients and clients to access services across the board and knowing that recovery flows across this continuum of care. And so whether someone enters high intensity treatment and then they go down a level after a while, and getting them from one place to the next and navigating that system so the recovery goes across the board. Thanks.
Ryan, I also think that if we can try to facilitate recommendations to facilitate open communication between the emergency medical system, law enforcement, around especially those individuals that are, you know, high needs or at risk, is important, as well as figuring out a way to collectively address the social determinants of health that might be affecting their ability to seek appropriate treatment.
This is Ty.
Oh, go ahead.
Go ahead, I'll wait.
I was just going to say that, you know, I think obviously we need to have better care coordination, chronic care kind of model, like similar to primary care, where if you go into the hospital for a heart problem, when you come out of there, you have an appointment with the cardiologist and you connect with your primary care doctor as well. We need to be doing the same thing for substance use disorders and mental health issues. However, right, providers can't do that unless they have the resources, which means payment, to be able to do that. So they can have staff and the systems they need to be able to track when people are coming in and out of the hospital or residential treatment or anything like that. So it has to be supported in some way, or providers won't. Everyone knows that it needs to be done. I think they all struggle to figure out how to do it with the limited resources that they have.
And I just want to say, you know, that expanding services can be a cost savings in a lot of ways. I keep bringing it up, but when I worked on the behavioral health plan, the Behavioral Health Transitions Council's high-end utilizer report, we narrowed around 20% of the population that uses around 80% of the resources, and many of them use them for social, have problems with social connections. I joke when I say, you know, Medicaid should be paying for Match.com or something like that, but it's a true statement that if people had better relationships, better social support network, and more, I don't even want to say non-traditional, but like traditional things like exercising, access to gym memberships, then we would save money, because the population that's using up all the resources wouldn't be have such difficulty, which is one of the reasons why I continuously bring this up. Is I think it's time that we redo that report and find out what the populations that needs are, and how we can service them in a system of consumer quality. You know, something that was big from the last high-end utilizer report was that most of these people entered the system as children and youth, and because they went through the children and youth system so inappropriately, they continued to go down multiple systems and wind up using these services. So I would suggest, you know, really finding out what it is that our peers need, and advocating for things that, you know, would actually help solve the problem versus just put a temporary stopgap on the measure until next week when they feel the same problem again.
Yeah, I think that leads really to the next piece of this is like, how do we do that? How do we, I mean, create that system of a comprehensive, I mean, appropriately funded providers are reimbursed at a rate to actually provide the service that we require of them, or that we will be requiring of them, right? So, I mean, and I mean, keeping in mind that there is this economic struggle going on as well. But then it's the piece of how do you prioritize, right? Like, how do you prioritize? That's why I put in here the question about what is cost savings? What does that look like if we have a comprehensive system, if we have recovery supports happening throughout, like what are the cost savings? So the folks that relatively low cost things that may help someone maintain community living and maintain an outpatient level of care rather than utilizing $6,000 per day emergency room for their treatment, right? So it's like that, those are the numbers that, I mean, I think we're trying to get at here, right? Is that if we have a better, more robust system, that some of the higher cost things, those costs will go down. But it also comes with how do we actually measure all that stuff as well?
Hey, it's Rachel. I just wanted to follow up too that, because I'm going to talk about work, right? So work is absolutely part of a cost savings. And I think that it's important that IPS is in treatment centers as well, individual placement and supports for getting people back to work and having that that social interaction and all of those things is super important. And it is absolutely a money saving program for people that need help.
Yeah, everybody keep that in mind, because we're going to be talking about IPS and peers in IPS next month. So thank you very much, Rachel, for bringing that up.
Yeah, absolutely. Work is important for recovery, for sure.
You know, and I just want, this is Brian, I just want to mention as well, am I muted here? Yeah. I just want to mention as well, you know, I know this is a treatment presentation and this is all about treatment and all this other stuff. But I think the question was posed, how can we save some of the, some of this cost saving? And we're talking a lot about how do we implement recovery services into treatment. But what if we like shifted our perspective, right? Because it's from a financial standpoint and from a just kind of revolving door of the same kind of what Ty was talking about, the same 80%, the high-end users who continuously kind of are just stuck in this revolving door of treatment. What if we implemented treatment services into recovery and gave all the money that we're dumping into treatment to recovery? And that wasn't a joke either.
Or at least some of it.
Well, I think the other thing to look at on top of that is our system is designed for the healthy. It's really hard to navigate. And so having for those, you know, high needs individuals, really having that robust hand-holding access for someone to walk them through the process, whether that's a peer or however that looks. But it's really that idea of how do we help them not keep going through the same doors over and over again. And I think that's something to consider as well.
Yeah, absolutely. And I'll kind of add on to that, you know, the mindset, right? When we do walk people through, you know, clients, whoever it is, through this, at least the beginning stages of this process is, okay, first stop treatment. And Ryan said, you know, something pretty important, you know, how can we keep people within the community structure and being, you know, immediately becoming productive within their communities, because that's really where long-term sustainability happens, right? It's you know, I just think there needs to be a big perspective shift when it comes to the process. And I just tell you from my personal experience, treatment failed me every single time. It wasn't until I started with recovery that everything changed. So.
Yeah, I just wanted to add on to what Victoria said. I think, you know, having someone as a navigator or someone to help navigate through these systems of care would be beneficial.
This is Mark at OBH. Just wanted to chime in. I think this is a healthy discussion and really worth exploring. I put in the chat kind of my thoughts about, you know, this group can kind of make that recommendation. I think, you know, OBH worked on the development of a recovery strategic plan. It was actually embraced by the legislature before the budget cuts. There were a lot of budget initiatives in there that we're going to add some funding for recovery support. So there's some desire to do that. We're using some of our SOR grant to do some of the things that the legislature had wanted to do in this regard. And some of that was around paying for recovery housing. A lot of it was for RCOs to do peer-based services. But I agree that kind of a recovery-ready community can do a lot to both help people who get out of costly treatment to maintain the gains that they achieved, which is a good way to make sure that the investment the healthcare system puts in to people's health is actually beneficial. But as you're mentioning, you know, it can go a long way to preventing people from having to get deep into the treatment system, because it might be able to catch them earlier in the progression and give them the supports they need. So yeah, I think it's a worthwhile discussion and it could be a formal recommendation. And I see that comment about getting HCPF to adjust funding structure that pays more equitably for recovery services. You know, that's something as well. That I think that's worth exploring and kind of working with HCPF on that piece. And this group certainly can kind of make some recommendations. There was part of the legislation was really around having peer services. Right now they're funded when they're part of a Medicaid provider. And so the bill that was presented last year that didn't eventually get funded because of budget cuts was the idea of allowing RCOs, recovery community organizations, to somehow get some sort of approval around their standards, make sure they had certified peers, that type of thing, but allow those peer services to be reimbursable by Medicaid without necessarily having to be connected to a community mental health center or large treatment system, so that you could really have those standalone peer services to some degree. So again, I think that in terms of long-term sustainability is a really worthwhile model for exploring.
I also think that there's some value in providing messaging that we all need to work together. You know, the funding structure itself has provided that ability to silo, which I don't think is in anyone's best interest. So I think it's that, you know, really, like Margie was saying, that really kind of wraparound process for a lot of these individuals, and the idea that we are in this for them and to get them the help that they need and provide kind of that supportive autonomy, for lack of a better way of saying it, is something that I think could be beneficial for the entire community.
Yeah, I mean, I think all this stuff is great. I mean, it's coming up with the, I mean, what are the next steps here? I think there's the one piece that how do we feel? So if we shift gears a little bit and go back to kind of traditional treatment here, traditional treatment running along a continuum from like outpatient all the way up to high intensity residential, and then like we kind of counting that as the community-based system, and then once you get into inpatient, it's a different system, right? Because that's more the medical inpatient side of things. So that community from once a month therapy in an outpatient setting to like, yeah, 3.7 level. Do we, so I guess what I'm struggling with is how do we kind of define a treatment system across the continuum? Do we run a parallel continuum for recovery services? Do those, are they just meshed together? Right, so I mean, I think we talk about continuums quite a bit here, right? So there's continuum of prevention, going from prevention to treatment to recovery. Like that's kind of one of those, or early intervention to treatment to recovery, and kind of more of that circular model. And then we kind of have a continuum for treatment, right? So if you look at the STD side, the outpatient, intensive outpatient, partial hospitalization, the 3.1, the 3.3, 3.5, 3.7 levels of care. Like, how do we, like, so when we're creating standards, or, well, first off, we should say, is that an appropriate continuum? If we're talking specifically about treatment, and does that structure work across both mental health and substance use? So then can we start integrating or start establishing a continuum that is a behavioral health continuum? And then what does that continuum look like? And on that continuum, are we talking that every region, every community, every county should have service providers providing services on every level that we identify on that continuum? Or what does that look like in distribution of, or look like in service delivery? Another big piece to this is, and then the other piece is, how does telehealth fit into this to get access to folks that maybe it's bricks and mortar, or there's not a community or a large enough community to really support the bricks and mortar facility, but how can we best utilize telehealth to make that an option to gain access for folks? Or mobile vans, or the MAT model for the Winnebago MATs, right? So like, I mean, we have some stuff kind of moving along. Like, is there pieces that we can utilize to, like, oh, this is working well here in this system or this delivery? Like, how do we, can we move that to something else as well, or expand that to provide other types of services?
Brian, this is Margie, and again, I think the frustration for me is listening to actual families, actual people, and people come up with things in their planning, but there really aren't those things available. So treatment is such as one piece, but it is such a small piece of people's lives. So when we don't have a process that really can individually address what is happening within that family or that person's life, it just it can't work. I was on a call regarding it was a planning call for a family yesterday, and in that process, everything that was suggested to be done was all going to happen next week after this assessment tool was done, and after this. There was always something that prevented it from happening now. And then there were times this girl was the family was in crisis because there was escalation of behaviors. And so I think we just have to look at what are these barriers. We can't get into this program because we have to have this assessment done, and we can't find someone to do that assessment till next week because we're not sure who's going to pay for that. If we just look at the barriers that it takes to have one thing accomplished, it's mind-boggling if you're on the other end of trying to get help. And so I think we can look at just some of these concrete things that it's not so hard if we would look at the policies and procedures that we have in place that prevent things from happening in a timely manner.
So what do people think about that last bullet? So initial contact should be about a person's immediate needs, not payment and paperwork, right? So it's not the initial intake or initial wherever you receive services from, whether it's, I mean, first time in recovery or a recovery organization, like it's not about like, oh, how are you going to pay for this? Or like, oh, I need to fill out all this paperwork because I receive federal funds. So I have all of these data reporting things. So on the front end, I need to make sure that like all of these boxes are checked, right? I mean, really coming up with what is that process for wherever you're receiving services, no matter what those services are within the public behavioral health system. It's about the immediate needs of an individual and really coming up with so I think a lot of these start running together then, right? So it's about individual needs. It's about across the board services, not just about, oh, I do this type of treatment. Well, I mean, this type of treatment is maybe one piece of the larger puzzle of what the person needs, right? Like, so, like, how do we actually access different, what we currently call different systems? Like Margie and everyone, that's kind of what we're talking about, right? Where it's a cohesive system across all service delivery systems, whether it's, I guess, thinking about emergency services or acute care crisis slash type of services. Like the more traditional, what we think about is the routine scheduled treatment services and the recovery services that, I mean, that essentially cover everything that an individual needs in their life to feel or be successful in community living. Right. So how do we mesh all those things together and make sure that, I mean, kind of going back to the first thing Margie brought up is like, how do we make sure that when you're transitioning between places that it's clearly defined on what needs to happen upon a transition, right? So
I would just comment that sometimes the person might be a little too young, so it might be the person's and then the family's immediate needs. And then it would be nice if we could move on past immediate needs too, to support, like you were saying, what sort of supports does a person need to thrive in their community, and be a participant in their community. That it'd be nice again, I say this with a grin on my face, even though you can't see it. If Medicaid would pay for Match.com or eHarmony or something like that, I think they would save a fortune. You know, with I think social determinants and social connections is something where in my experience, the system has destroyed, and it pitted me against my mother. I wasn't allowed to make friends growing up as a teenager, and so I wasn't ever allowed to date anyone. I've never been on a date in my life, and I'm 36 years old. And a lot of that has to do with the system never allowing me to do it as a child. And then doing it as an adult is almost an impossible task because I don't know where to begin. And people expect me to have a certain skill set. And I think I see a lot of my other peers out there with very similar problems, that they don't have the same social savvy skills, where they're able to form relationships. And so when we were doing the high-end utilizer report, we would hear about a lot of people who it was Friday night, they were feeling isolated and alone, probably now more than ever. And so they would start drinking or using substances, and they would wind up overdosing and going to the ER. And this would happen several times a month. So, you know, I don't want to say non-traditional because it shouldn't be non-traditional, but paying for things like helping people find social connections or helping people exercise, where the evidence shows that exercise does wonders for the mind and body and spirit. You know, those are some of the things that I would like to see invested in a little bit more. And I know all about Phoenix, which is a great, wonderful program, but unfortunately, I don't think I'm qualified to use it because I'm not in recovery.
Well, and I just put something in the chat. I mean, to Ty's point, I think, you know, I think the peer programs are amazing, but they tend to focus more on the SUD side. But I think that looking at recruiting peers for those with mental health, any special needs and substance abuse, and even maybe family mentors could be something that we might want to look at, because I think there's some people that just need to know that there's other people out there that have experienced what they've experienced, and have been able to and have been resilient in that situation to help them with their.
So with COPA, the peer specialist certifications that they have to do both mental health and substance use for their training. And they also become peer and family specialists. So they're being trained for not necessarily the special needs. I don't believe that there's trainings on that. There might be some classes that they take, like electives that they can do in regards to that. But yeah, they do, to get certified with COPA, you do have to have a real overarching training to be a peer specialist here in Colorado.
So in order, yeah, maybe this off topic a little bit. So do folks know if an agency employs peers, do they have to be credentialed with the ICNRC credential to be a peer within an organization?
If they're not, oh, sorry, go ahead, Jacob.
Yeah, they do not have to be credentialed like with ICNRC. That's just the certification for the peer specialists themselves. through the state of Colorado right now in COPA, as Aaliyah was talking about.
If you work somewhere that that Medicaid, that you can charge Medicaid, then you do have to be certified. And if you don't, then you do not have to be certified right now.
Yeah, so I guess what are people's thoughts on that? Like, should there be, I mean, that standard, the state standard for credentialed in order to receive payment? Because I think there's two things going on there, right? Like is there a burden to be credentialed as a state certified peer or whatever, the IC and IC certified peer versus like we have a bunch of staff that provide really good work that aren't currently state certified, so there would be a burden for us to go down that path, right? So I think going back to Ty's initial thing about 1139, is that going to be an issue moving forward? Like I don't know what the new bill is going to look like. Is it going to require that any individual working within one of these RSSOs that is approved must be credentialed in order to receive Medicaid funding?
This is Mark. I definitely think when you start to look for public funding, the public is going to want to see some standard of care. And that's where, and right now it's private certification, right? And we see the same thing in recovery housing. There is some public dollars now going to support people to stay in recovery housing, but it needs to be CAR certified. And so if there's going to be public funding for peer services, there's going to need to be certification. Right now, IC and RC is private certification versus a government license. At some point, the industry or the payers might say, we want to up our game a little bit and we want it to be, you know, a DORA credentialed peer, you know, state government credentialed. But right now, you know, the peer groups have said, hey, let's go with the IC and RC credential. But that's something to be expected. And so, you know, we're funding some peer training through our SOR grant, and I know there's other grants out there, but that could be another piece of that. If we are going to have funding for peer services for, you know, uninsured folks through our office, through Medicaid, for the Medicaid covered people, you know, building the peer workforce, and that comes at a cost, is another place where there may need to be investments.
This is Margie Grimsley, and I also always want to make sure we include family advocates as when we talk about peer specialists as well, because there is a distinction between them. But there are people doing this work. Libby Stoddard, that's part of the Federation, has been part of the IC and RC review group. Sherry John, I think, was on one of our calls a couple months ago. And she's with COPA. There are a group of people that are working on this right now. So it might be helpful for us to learn from those folks that are actually doing the work of this credentialing, and really thinking of the pros and cons of what level of credentialing people need. Because we can have too many layers of credentialing, and or there can always be a danger when it's only one place doing the credentialing. So really, I think it's an important conversation, but actually a lot of it is already happening at the state throughout our state right now.
I guess my concern, and I don't know how well this fits in, but when professionalism overtakes the values of peers, and I've seen this happen nationally, where people are so concerned about being a professional and being, you know, treated with that level of respect and level of duty, that they lose the values of what it's like to be a peer and what peers need and peers want. And I'm pretty anti-professional myself. You never see me in a suit and tie unless I can somehow manage to tie-dye it. You know, I think it's really important to have the values of the peers and the values of the communities that you're working with, and making sure that you put them first. And what it is that they want and what it is that they need and the supports they want, rather than trying to, and I hate saying this, part of me hates saying this, but they should come first before looking at how much a person should make, and not to not value the peers at the same time, but it's just I just think professionalism has done us a world of harm, and I just want to make sure that we don't lose track of what the essentials of peer services is, that we're peers first.
Ty, can you elaborate on that? What you mean by a world of harm?
Well, we've had mad doctors like Henry Cotton and Walter Friedman who wanted to find the cure for mental illness and wanted to be treated like doctors and professionals. And because of that, they would do horrible things to our peers. Henry Cotton, in my mind, is one of the worst monsters in human history, and yet hardly anybody knows of him. He believed that mental health came from a focal infection, and that you could cure mental illness by ripping out your teeth and then your intestines and then your colon and just work your whole way through the intestinal tract. He had a 40% mortality rate and would do all sorts of terrible things to the people that he treated. And he was a foremost authority when it came to mental health during his time. And the scary thing is his work is being continued, and there's still people who believe that focal infection is the root cause of mental illness, and it's coming back. I won't deny that poor dental hygiene has a lot to do with physical health and potentially mental health, but I don't think you can cure someone by ripping out their teeth.
Ty, this is Mark. I think you're bringing up an important point for us to consider, and I think I don't think we're ever going to try to over professionalize things like in 12 steps, which is completely independent, and there people can be sponsors. I think those and there are peer support groups, self-help groups that exist across the spectrum of behavioral health that are truly peer run and aren't necessarily based on an income model. But I still think we could do a couple of things. So for services that are going to get reimbursed, like a peer-to-peer service, and that includes family advocate service, that's reimbursable, I think there is some benefit to having some standards and some standard baseline training so that there's some trust in that piece. But one doesn't necessarily negate the other. I think kind of a full spectrum makes sense. So that's my 2 cents.
I agree, and I believe that standards should be put in place. I just don't want to lose the essential of what peer delivery services are in the process of trying to make them into a profession. I'm full support of 1139. That was last year, and hopefully it's going to bring back this year. I just want to make sure that in the end, we don't have to sell out our values in order to become providers.
Gotcha. And I'd also say, Ty, that having people with lived experience more integrated throughout our treatment systems will hopefully prevent some of those atrocities that have happened in our history by having people without that lived experience, thinking they know what's best without the consultation and involvement of the people who are getting the service. So that's one of the other benefits of moving in this direction of not just having standalone peer services, but peer services fully integrated within our healthcare systems is that those healthcare systems become more accountable to the people they serve, and because they're able to run, hey, does this, we want to do lobotomies, does this sound like a good idea to you? And having people with lived experience there to say, no, that's asinine, is going to help our system.
Yeah, I think what we're talking about is that one size doesn't fit all. And people who are in need of treatment and recovery services really have to kind of be their own guide. And I think that all pathways and multiple pathways is really important to consider as well, including the lived experience. And if a paid peer helps someone, then we should be able to provide that to that person who can have value from it.
I do want to interject because it came up last meeting too, and I didn't say anything, but I would be remiss to not say that that there are a number of professionals in the community who have their own lived experience. So I just wanted to say that even though we may not be peers, we've gone through our own journeys. So I just wanted to say that.
This is Marcella. I really think we need to keep in mind that there are excellent and poor plumbers. There's excellent attorneys and lousy attorneys. And there's somebody with lived experience is not perfection, right? Over the years, I have hired a couple and it was a nightmare. And some of it was because they, in the cases, specific cases that I'm talking about, did not like standards, did not like rules, did not like policies, and it became a nightmare. In any organization, you have to have standards, you have to have a process that everybody can go by. We can't have people runaway trains, right, within that organization. We have to work together. And I think I just wanted to say that because it seems like there's earlier, right, that treatment fails, or with ASAM, we're trained that the client is not failing because they come by once or twice or even a third time, right? Doesn't mean that they failed the first or the second. We just need to keep in mind that all of us are doing the best that we can. I really support standards. I support credentialing. I am very cautious when I look at those systems that they don't present systems for credentialing that then impede critical individuals, critical to the process of being able to achieve it. Right? Oftentimes those things are discriminatory. They're very biased. It's difficult to become credentialed. So I take a look at the systems that are presented and assess it for those kinds of requirements that impede, right? We impede somebody getting in. They need to be a healthy process and not so complicated that it discourages individuals from applying. I just wanted to say that because having lived experience, a peer specialist, for example, it does not mean that that they're perfect. That's not going to work for everybody either. Neither does treatment. But I wanted to say that because it seems like we're talking about for me, negatives about certain things that aren't necessarily negatives about the system. Person might not have been at the right place at that time. I also, in terms of what Margie was talking about earlier, because I feel like, I don't know, I'm trying to keep track of all the different things we're talking about, but when she encouraged us to create systems, handoff systems, transitional systems, I am so pro that idea that I would actually like for formats to be developed where we actually sign off, right? They called IDEA, let's say a residential treatment calls IDEA, and the handoff is to us. We sign off on the fact that we're taking that client at that point. And then if I refer somewhere else, the very same thing. So it's so well documented that we're held accountable to make sure, because sometimes I feel like we talk about almost as though it's pie in the sky. And I think, Victoria, you are the one that said earlier, everybody knows this is needed, the transitional care. Everybody knows that, but we don't create a system where we're actually held accountable to make sure that we do that. So I wanted to encourage that we do develop a system that holds everybody accountable. If they're MOUs, whatever it is that we develop, that we actually sign off for the care of that client and run with it. And then the same thing if we do it to another organization or another private clinician or a recovery coach, whatever we're going to do. I'd like a lot more accountability around that, documented accountability. That's my recommendation.
Yeah, so I know Mark has to run here in 2 minutes. Anything else you want to give from Mark before he has to jump off? He's our in-house expert of all things treatment and recovery and the behavioral health system as a whole.
I'm uncomfortable with that title, but whatever.
I think, and I know I'm sorry I keep interjecting, but my other concern is that at least here in El Paso County, when we have some super high needs individuals that we've tried everything with and trying to get them the help that they need but don't necessarily want, and the legal means have not gone in our favor. We end up then having to rely or hope that they get in jail so that we can have some time to try to get bail safes in place for them, for their own safety and for the community's safety. It's something that, granted, is often outliers, but there's enough of that issue that it becomes a real issue for the community as a whole. And so I just don't know if that is something that's further down the road, but it is something I just wanted to mention as a concern.
Yeah, Victoria, we've heard that as well, right? Where, I mean, kind of the de facto behavioral health system is the criminal justice system, especially for those folks that are, maybe it is that they don't realize that they need the help, or that the voluntary system doesn't work, or even the civil involuntary system isn't quite meeting their needs. So then what happens then? I think there's a lot of things that, are issues, right? Where, SimHip, our state hospital in Pueblo, is overflowing with forensics folks, right? So like throughout the last 50 years, like the state hospital was that place for those folks. So it's not the criminal justice system. They're still in a hospital setting, but we just don't have those beds now. So like what is that system look like? Because there was that piece of what in the 60s with President Kennedy is the whole process of like deinstitutionalization. But then that didn't bring the funding either, right? Like people out of institutions, yes, 100%. But then how do we actually have the services in the community that support those people that traditionally were institutionalized? Right? So and I think that's where we're struggling now, especially with those folks that you're specifically talking about. So it's how do we come up with that system? And I think that, I feel like I've been beating this drum on 222, but I think that is part of it, is like, what are high intensity behavioral health services that individuals that you're specifically talking about need to have access to? Essentially in every region or community or county or whatever, however you want to break down the state. So it's not just a singular place has this to like do a certain high intensity thing, right? Yeah, so it's one of those things we got work to do, right? But it's stuff that I think we're all smart folks here that have experience in this and have ideas that really right now as we're putting it on paper, right? So it's over these next couple months, we'll be formalizing these and coming up with, well, what are these two clear recommendations for how to improve the system? And yes, and I mean, I appreciate these conversations. I mean, yeah, it keeps me optimistic that we have people that are working within a state system to really establish those statewide changes that are going to be beneficial for people. So
I think on the flip side of that, Ryan, is that the system needs to work with the community to rebuild trust. That the person isn't just a paycheck or a checkbox, you know, that we are actually trying to work in their best interest with them. And I think it falls on us too, as a system, to try to reestablish and fix the harm that they may feel has been caused to them.
I think you hit on a really good point there. Like, yeah, I think right now it feels like there is kind of a lot of mistrust, right, between the state and providers, potentially between, I mean, consumers and providers, as well as providers in the state, not like accounting for the needs that they have, right? So I think you're exactly right, is that, I mean, maybe that's a long-term goal of BPAC as well, to ensure that BPAC is, I mean, and that's, I think, the ideals of BPAC is making sure that people have a voice to express things or their concerns with the system, and then come up with plans for how the state actually addresses those concerns, which, I mean, I think that is BPAC in a nutshell. That, I mean, we want to get there where it's like, here is that place for, yes, I have concerns and my concerns are being addressed. And then, I mean, yeah, hopefully we move to that spot where a spot to kind of air your concerns, as well as, I mean, making sure that they are being addressed and positive changes are happening. So we got Caitlin to take over the show from.
Good morning. Yeah, exactly. With 30 minutes left of what would have been my part. So sorry to be late.
Yeah, so I guess with this, to me, it feels like the next steps is, so a little bit of behind the scenes is that I will kind of put these bullets from today's notes more into topic sections, if that's okay with folks. So the next 2 months, so just some business. So over the next 2 months, it will be recovery, right? I know we've talked a lot about recovery and the treatment here, but I think next 2 months recovery, and then after that is then we'll be breaking out into really starting to formalize what these recommendations from each of the 3 realms are: the prevention, treatment, and recovery, right? So then it's leads up to the block grant application with clear and concise recommendations for what we want the system to do for us. So, I mean, I think in the meantime, you are always welcome to send ideas, send recommendations, just send concerns, questions to me or anyone else at the state, or at OBH, I should say. I suppose I shouldn't talk for other state departments. At OBH, if you have questions, don't feel comfortable talking about them in here, send them to me. We can kind of add these. I will even be your champion if you want it to something to get addressed in BPAC, but you maybe don't feel comfortable with it. I will be the champion to bring it up. So kind of an open invitation for that as well. So yep, yeah, I mean, I get a ton of questions from all over the place. So yeah, I offer that to everyone here as well. Even those folks at OBH, if you have questions about things. Looking at you, Aaliyah. Aaliyah and I talked quite a bit about just random things. With that, where are we at with how people are feeling? We've been going along here for a good hour and a half.
I'm okay for a break.
Jacob, you took my bait. That's what I was going for, right? All right, we good with that? So, well, Caitlin's our chair today. She can make that decision for us.
Yeah, yeah, exactly. I show up and then I get to take a break. So yeah, I think that we had like a, per usual, a 10-minute break on the agenda, and then we were going to hear from you, Ryan, about the OBH updates. So maybe come back at 10 to 11. Does that sound okay?
Sounds good.
Okay, see you then. Give it like 1 minute, 30 more seconds for folks to get back. Okay, I would say, Ryan, kick us off and folks will join as they come back.
Yeah, so during the last meeting, we talked about having the MHTCJS task force update from Ty, as well as the State Rehab Council from Marcella, part of the OBH update section. Do either one of you have updates?
Thank you for the invitation, Ryan. I just received my orientation. I have not attended a meeting. Our next meeting is December 9th. So the timing for a report today is off, but I will have those coming. So very first meeting is next Wednesday. But the orientation was great. I'm really glad. It's an area that I was involved with on and off over the years. So I'm really excited to be on it, and they were wonderful. They actually had 2 people giving me an orientation, and I was the only one being orientated. So I felt really special. So that's my report this time.
Marcella, can you give us some examples of your orientation for the membership committee? That might be helpful for us.
Oh, their mission, their goals, the purpose, names, the structure, right? Why it was created, their purpose, their responsibility. I would love to share even the schedule, because they actually provided me with the schedule of the orientation, but it was extremely thorough. Why representation from this group is so important to that group, and all of the other representatives, that was extremely helpful. And then it was the orientation included a presentation on each of the committees. They did not ask me to select one. During my orientation, they did ask if once I received the information, if I was more interested in one than the other, just as an initial feedback. I really liked their membership committee, but I also liked one for the program developments. But I have not decided what committee I'm going to be on. But that was a big part of the orientation, was the purpose of the council, and then the purpose of all of the different committees, and how they report their annual report that they produce. So I thought it was extremely well done.
Well, thank you.
Thanks for asking.
And then it was Ty, right?
I'm sorry, I stepped away for just a minute. Is this for the report for the MHCBJ?
Yeah, correct, Ty. So the Mental Health Disorders and Criminal Justice and Juvenile Justice System Task Force update.
Not much happened last committee that is really relevant to our group. A lot of internal things, finding and discussing open seats in the committee. We had a presentation 2 months ago from the Bridges program that I can send off to Donda, and maybe she could send it out to the group. It was really helpful, but we just kind of followed up on that and discussed, since we can't bring legislation ourselves, how we might support legislation that we like within the committee to the legislative process. So there wasn't much in this last committee that I think was really relevant to our group, so to say.
Yes, thanks both of you. Yeah, we'll just continue to do it like this. So just the first part of the OBH updates. We'll do the task force reports. I will share my screen again, as sometimes it's easier for folks to just follow along with me on the screen if that's okay. Right, so I have them written out every day or every month to allow Donda a little bit easier to get these into the minutes. So some of this may feel redundant once we move a little bit further, but really I wanted to start with the special session that ended yesterday. It was for 3 days, started on Monday, ended on Wednesday. 10 bills were passed, none of them specific to behavioral health. I have the 10 bills here and links that should work when they get put into the minutes as well, if you're interested in them, with brief descriptions on each one of the bills that passed. Right, so internet access for preschool through 12th grade education, right, emergency relief programs for childcare, food pantry assistance grant program, sales tax for retailers, local authority to impose food delivery fee restrictions, insurance premiums, tax payments, and credits, and then COVID small relief and minority bus organizations. Yeah, there's also, most of these have appropriations included as well. Right, housing and direct COVID emergency assistance through DOLA, and then emergency utility payment assistance, as well as a one-time transfer of $100 million from the general fund to the controlled maintenance trust fund. So it's really a disaster emergency fund if needed, that the governor has a little bit more control over. So those are those. If you're interested, like I said, I'll have these links there.
Ryan.
Yep.
Ryan, can I just ask, it seems to me that since COVID has created a lot of stress for people, and that translates then to additional substance use. Did they even discuss anything in the special session? It seems like that allocated some extra dollars, in my view.
Yeah, so with the governor calling a special session, there was a specific topics that could be addressed in that special session. None of those included specifically behavioral health, right? So then with that, within those parameters, these were the bills that came up with. Within a special session, every legislator has an opportunity to run one bill, so 100 legislators, right? But we're also there are outgoing legislators, so I don't even know how many people participated, right? Because there was people that lost elections, right? But they were still the elected officials. So it was one of those ones, I didn't see a single bill drafted related to behavioral health.
All right,
So,
thanks.
but it's more likely to do because of the governor's parameters. We do expect during the session, which starts in January, to kind of pick up the behavioral health slack that was missing in this special session. Yep, so that's those, it's done. So then there's a little bit of a down time between now and January for the session to start up, and then we'll hit it hard at the beginning. Usually during this time, we are talking about bill drafts from interim committees, right? So the opioid and other substances interim study committee usually has 5 or 6 bills they run every year. That committee did not meet over the summer, as well as MHT-CJS. The legislative committee that the task force essentially works for also did not meet over the interim, so there aren't interim bills. So hence the reason why there's no bills that we're currently reviewing at this time. So this time during a normal year, there usually is a handful of behavioral health related bills that we would have drafted or have drafts for, but that's why we don't so far. So with that, what's going on with OBH and the legislature right now is really the budget process. So November 20th, the Office of Behavioral Health had their JBC, the Joint Budget Committee briefing. So this is where a JBC staff worked with the Department of Human Services to come up with what are some of the priorities for the department as well as OBH, and that gets presented to the committee. The committee asks a handful of questions that over these, what feels like forever, but over the last couple weeks, we at OBH have been responding to formally in writing that will get submitted back to JBC, and then we'll have about an 1.5 to 2 hour presentation on December 9th, which is open to the public remotely. So on the website, you can listen to, it was originally going to be Robert. It's usually the office director that presents, but there's some family emergencies going on with him. So I'm not quite sure who's going to present the OBH's slide deck at the hearing, but it's more than likely going to be our deputy director or Camille, our community behavioral health director. So that's December 9th. Like I said, it's probably going to be about 1.5 hours talking about specific or answering specific questions from the JBC briefing. A lot of the questions are related to workforce, a lot of SUD specific workforce, a lot of stuff about the plan for what Medicaid expansion looks like, which honestly, I don't think we have a lot of good answers for that because we don't quite know yet. So it's a lot of that stuff, and some of it is related to increased call volume at the crisis line because of COVID, and transition specialist program. And so there's a lot of stuff, and as well as the cuts, like I talked about previously, the jail-based behavioral health services, a cut to that program of offender behavioral health services, which that's a lot of the community-based offender services, including funding some co-responder programs. So that was another cut. So it's explaining some of those cuts. So if you're interested in what that budget stuff looks like, definitely tune in on December 9th, and I'll attach some of the information. Or you know what, Donda, we can just send it out because minutes probably won't be available before the 9th. So I guess with that, any questions about the JBC briefing or the hearing? It's just one of those budget steps. So this is based off the governor's budget that came out at the beginning of November. We're a relatively small piece at OBH for that larger budget. So every office goes through the same process. So then with that, January 13th, the legislative session begins, barring any COVID-related emergencies, and it's supposed to end May 12th. Yeah, like last year, there was a hiatus for a couple weeks there, so I think it went into June. Those are the dates. Like I said, there are some bills that we're expecting. The Behavioral Health Administration bill coming from the Behavioral Health Task Force. My understanding, that bill essentially just sets the foundation for creating the administration, which not a whole lot of detail in that bill yet. And then there is a transition specialist bill. So the transition specialist is that program that currently works or allows hospitals and withdrawal management facilities to refer high-risk individuals, so individuals on holds or certifications or emergency or involuntary commitments, refer those into this TSP program. The bill draft is to expand who is eligible for the transition specialist program to include voluntary individuals, as well as expand who can actually refer to the program. Right, so there's more access to transition specialist services for individuals, not just involuntary individuals in withdrawal management facilities and hospitals. So we're excited about those bills. We'll see how that goes. And like we talked about, we've heard rumblings that a version of 1139 is going to come back. So we're expecting that. I've also heard rumblings that the psychiatric advance directive, that they want to potentially make some changes to that too, which was relatively new from a few years ago. So that's what I've heard so far. Yeah, so then there are, this is from last month as well, the OBH specific budget items. We did propose a budget request of almost $1 million to improve how crisis services, or how the crisis system manages youth and families. So interactions with youth and families need to be child and youth and family specific. So we're requesting funds to improve the training, as well as improve training for the crisis providers for managing folks with TBI or families with youth with intellectual and developmental disabilities as well. Yeah, so it's one of those things that, I mean, I think we've talked about it in here that, I mean, we realize that there's at times the behavioral health system is fragmented for adults. It feels like it's even more fragmented for kids. So this is trying to get to, at least on the front end for those crisis or emergency type services, that there are specific trainings available for our crisis staff to more appropriately respond to kids in need and families in need. So that's the basis for that request. IT investment. So Joint Budget Committee had a lot of questions about this. This is really trying to expand how telehealth and make investments in how telehealth is utilized across the state. So briefly brought it up in the treatment recommendation discussion is that, I mean, yeah, some places don't have the, or populations are distributed in some regions that they essentially can't maintain a bricks and mortar place. So how can we actually get services there? And really the idea is better utilization of telehealth, also decreasing burden on providers in the utilization of telehealth. So this is really us working with Medicaid to make sure that telehealth services are reimbursable and accessible. So with Medicaid expansion, so that's the couple weeks from now, I guess a month from now, the SUD residential benefit with withdrawal management, there we have requested a one-time reduction of $11.4 million for SUD treatment. This is really coming from 202 funds. So those are those more flexible funds directly to MSOs. With the thought being is that we had to cut our budget, but because of Medicaid and the expansion of roughly $100 million, we thought that the 11.4 from the MSOs would kind of, the $100 million offsets the $11 million because we had to cut money, right? Because of the economics of Colorado. There has been a lot of pushback on this and why it was from there. So, yep. So this was definitely a hot topic in the hearing and will be in the briefing as well. With that, this is what we talked about, JBBS and so jail-based behavioral health services. So the reduction in community behavioral health services. Yeah, so really the idea being we don't want to cut community programs, because if we cut community programs and keep criminal justice programs, it kind of sets the tone for, wait, services should then be provided in the jail, and we feel that services for individuals are most appropriate in the community and not in the criminal justice system. So that's really the basis behind the criminal justice programs being cut rather than the community programs. The last one we talked about last time is there's also additional money for Family First Prevention and Service Act implementation. This is really more through the Office of Children, Youth, and Families within the Department of Human Services, but the Office of Behavioral Health does have some pieces to that Family First Prevention and Services Act, like qualified kids residential facilities having to meet trauma-informed standards, and Office of Behavioral Health is the entity that approves those programs in trauma-informed care. So that's kind of the budget stuff in a nutshell. Questions about that? I suppose the 9th is only 6 days away, so.
Ryan, I have a question, not necessarily about the budget piece, but of the expansion of the IT services for telepsych. Has there been a discussion about what or talks about trainings for providers when it comes to if there is a need for any type of hold or anything like that? I think one of the issues here that we run into is that law enforcement won't transport a hold that hasn't been written by them, rightfully so. But how do you get a hold to the appropriate provider? How do we access transportation for those individuals? What happens if that situation while you have somebody on the phone or on video starts to get dangerous for the person on the video or potentially their family?
Yeah, so there definitely has been those discussions. Like, so with this process, we haven't been approved for this money yet, right? So, but there are those other discussions. Really, a lot of that was based off of the police integrity bill from last year, because a lot of law enforcement agencies were saying like, well, no, this bill, I mean, essentially excludes us from providing, I mean, emergency community behavioral health services, because any police contact, there has to be, I mean, reason behind it. And kind of our argument has been, yes, the behavioral health emergency, there's reason behind it, right? So there's been a lot of discussions about how we can better support law enforcement in that, but with that, there hasn't been definitive stuff. The Mental Health Advisory Board for Service Standards and Regulations, so that's the 2765 board. So 2765 being the statutory article for the involuntary care and treatment of individuals with mental health disorders. So that board has specific recommendations to better improve what that system of, or what the process looks like in the community when someone warrants some sort of involuntary procedure, whether that's the transportation hold or the M1 and the 72-hour hold. What does that process look like? What does the transport look like? What does law enforcement involvement look like? And what are, because current law essentially says that a list of individuals, an intervening professional can put someone on a hold, and they're essentially responsible for the custody. So that's what the law enforcement is saying. Well, if a licensed professional puts them on, it's their responsibility to get them where they need to go. That's what the law says. But it's way more nuanced than that, right? Like someone on a mobile response in their own car that puts someone on a hold that's imminently danger to themselves or others, the transporting of them needs to come from somewhere else. So really we're trying to work through all that stuff, which Victoria, I think that's exactly what you're hitting on, right? So there's a lot of moving pieces to all this, which a lot of legal interpretations that aren't in alignment. So yes, and Victoria, if you're interested, I can attach you to some of the pieces to that, because I know there's going to be stakeholder groups happening shortly.
Yeah, that would be great, because my biggest concern is we already have a provider shortage, and if we have providers out there that lose their license or are concerned about losing their license in these situations, we run into an even harder issue, you know, a more acute issue around that kind of situation. So it just makes me anxious.
Yep, and we're with, and yeah, that is part of the idea, is that if we are allowed to invest more in telehealth through IT investments, I mean, that really kicks the process up of, we absolutely need to figure out what telebehavioral health looks like for placing holds and those emergency-based services. Because we know that in rural Colorado, some counties don't have a single licensed professional in the whole county. So it's one of those, how does that work then? Because there are people in the county that potentially have behavioral health things going on. So definitely on the radar, and yeah, we'll keep you as well as the council informed on that.
Ryan, this is Margie, and I wondered in doing the council's recommendations, are any of those, is that what you're reporting separate from our recommendations, or do you have suggestions on how what you're reporting here intertwines with the recommendation process that the council is doing?
Good catch, Margie. So this is exactly why I repeat these things, because these are things coming directly from the department and OBH saying, General Assembly, we need this money for this purpose. And I think that is where we've talked a lot within Bhpac about, there are specific recommendations for the block grant, and then there are specific recommendations for the behavioral health system as a whole. Like, this is really the opportunity through this process, is that if we as Bhpac have recommendations to how to better improve the system, it can go through this process, right? Like, these are department through the governor's office saying, this is what we think the system needs. And this is general fund money. This is related to, I mean, state appropriated money to the department, not federal block grants. So I think I probably repeat this a lot, but there are really two separate mechanisms for what Bhpac can do, right? Block grant recommendations are this specific task of Bhpac for the block grant application. That's that $42 million worth of funding. But it's much larger than that with what Bhpac can do. So that is what, if you have recommendations that maybe were specific to the block grant, but don't essentially meet block grant requirements, or we can't use the funds for it, that does not mean that those recommendations just go to the wayside, right? We use those in other forms. So this is one of those ones where maybe there isn't block grant funds that can get utilized for things, but if there are other funds that are available, having clear, concrete, concise recommendations, they can, I mean, merge into a different format just like this. But Margie, to answer your question specifically, these recommendations for funding are different than Bhpac's recommendations. But the thought is that y'all should be very mindful of what these recommendations are, to make sure that, or your Bhpac is aware of kind of priorities through the governor's office and the department and OBH, because these really are priority areas for the department in funding, right? Obviously, all of OBH's funding decisions, all the department's funding decisions have to be approved through the governor's office. So if these have been through this process and are actually getting presented to JBC, they have governor approval. So
Just this is Margie again, just to clarify. So if we see things in this list that maybe are gaps, where there are gaps, then would that then have us think in terms of how they possibly would fit into a block grant recommendation? Or do you just see them it's just important to be aware of both parallel tracks.
Yeah, I think it's both, right? Like if you identify gaps here or that we completely missed on something or this is completely unwarranted, there's still that process of BPAC not agreeing with these recommendations or these budget requests, right? I mean, that's its own thing. So this whole process goes is that this is so the hearing, or so the governor's budget that came out on November 2nd contained these budget requests. The JDC's budget requests are to JDC, who then talk to us about those requests, and these eventually get put into the long bill if JBC approves. So that's the whole piece that it goes through the legislative process, right? So during that time is all of the sausage making of the General Assembly that comes up with bills and kind of how all those fit into this process as well. So, I mean, we're essentially working directly in tandem with that process. So if we start identifying things like, oh, this bill or this budget item has these reductions or these increases, but we as BPAC think that it's better suited here, like that BPAC has that ability to make those recommendations, right? So that's why I'm saying it's parallel but the same, right? Where it's like we need to be abundantly clear that like block grant is a relatively small piece of the funding puzzle at OBH, but that doesn't limit BPAC to just that either. Other questions about funding? Yeah, I really think that if you do have interest in OBH's funding stuff, listen to that hearing on the 9th. Because yeah, I think you'll get a lot of good information about kind of the behind the scenes about why certain decisions were made. So the last piece that I had in here are OBH rules. So tomorrow I go to State Board of Human Services to present controlled substance licensing and opioid treatment program rule update. So we've been talking about this one, what feels like for ages. This is the one that aligns our controlled substance licensing with the bill that passed in 2019, Senate Bill 1919, as well as updates our opioid treatment program rules to better align with the federal requirements for OTPs. Not a ton of stuff going on within this rulemaking packet. Our current rules have we define OTPs as OMATs, so actually using federal language, and that's the language that these programs actually use. So just as to quantify what we're talking about here, there's currently 28 OTPs in Colorado, and 51 agencies have a controlled substance license. So there's not a whole ton of providers, right? So it's not a ton going on within these rule and this rule update. Really the big piece is that we are clarifying that there's an exclusion for office-based opioid treatment providers. So this is those MAT providers in primary care offices that have a Data 2000 waiver. So those are federal government approved providers to essentially prescribe buprenorphine type products in their primary care setting. So those organizations do not dispense, compound, or administer controlled substances, they prescribe. So that's why they're excluded, and we're confirming that they're excluded from the controlled substance. So probably a lot more information than you wanted or even needed, but that's OBOTs. So if you hear that term in the future, they are independent and they have a DEA license to prescribe buprenorphine, and they don't need state oversight to do that because the DEA oversees them. The bigger one, addiction counselor rules. So they are in line to go to the State Board of Human Services on January 8th for first reading. So second reading and adoption would be February 5th, and those rules, if everything goes according to plan, would go into effect April 1st. So just to be clear, OBH's role in the CAC program is related to individuals meeting certain training requirements in order to be qualified to pursue the credential through DORA. right? So the Office of Behavioral Health is not the entity that says or enforces any of the changes from 1206, House Bill 2012-06. So it is not the Office of Behavioral Health that enforces that now CASs, the Certified Addiction Specialists, have to have a bachelor's degree. That is DORA that has to enforce that. The hours requirements or the clinical supervision requirements for a CAS on the 2,000 hours, that is enforced through DORA. So our rules are clarifying what OBH's role in the addiction counseling program is, which is essentially coming up with what classes do you have to take to be a technician or a specialist. And really that's the extent of our authority within the CAC program. We have been receiving a ton of questions related to why did you change this and why did you change that related to 1206. That is not the regulatory process. The regulatory process is really implementing 1206. A lot of those questions that a lot of providers have, yeah, I mean, those should have been questions that were addressed during the legislative process. So really, this is really our opportunity to talk about, it is important that if you have concerns with a bill and how that affects you or your organization, that is a legislative process thing, which essentially we can't fix on the back end once that bill's already passed and been signed. A lot of the stuff that has been coming up is workforce related to this, right? So if CAC 2s and CAC 3s are now specialists and require a bachelor's degree, that kind of limits a whole lot of folks from getting into the more clinical treatment side of addiction counseling because of the bachelor's degree requirement, when CAC 2s used to just be able to have a high school diploma or a GED. So there are some clear workforce issues related to 1206. Another one of those things that we will be addressing during the briefing on the 9th, right? There are some SUD staffing things that have been affected over the last couple months, even with the ASAM levels of care update and licensing facilities, SUD facilities based on ASAM also comes with additional staffing requirements because of access to licensed professionals essentially at all levels of residential care. So thoughts on that? Any other questions or any questions related to addiction counseling? Yeah, and so then I guess the last piece is that, which to be completely honest, doesn't necessarily make sense that it's at OBH, is that there's the continuing professional competency for technicians, specialists, and licensed addiction counselors. That continuing competency program is in OBH's rules. Every other mental health professional, so psychologists, clinical social workers, LPCs, marriage and family therapists, the continuing professional competency is all part of the DORA board. For some reason, for the addiction field, it is housed within OBH. So the rule update also creates a continuing professional competency program that mirrors the programs for other mental health professions. So 40 hours over 2 years you have to do to be eligible to receive or to renew your license or certification. Yeah, and then the last reminder, I've said this a few times, is that the SUD benefit for residential and withdrawal management goes into effect January 1st. And so have a full continuum of SUD services funded through Medicaid, and we'll see how that system works and if we have the capacity to serve folks and actually draw down those funds, because it's over $100 million in funds just for the Medicaid piece of it. So a lot more funds into the system.
Ryan, this is Margie, and again, I apologize. Everybody might know this, but if the people that no longer have, because they don't have a BA, or no longer have that ability to provide care, and then that's going to be, I would assume, a lack in workforce that's already a strained workforce. So even if there are more funds, if there are fewer people, what are the conversations about how to address that? What was a gap and now is going to be a larger gap in the immediacy, not, you know, again, it's 6 months or a year or 2 years, that might be better. But for right now, what do people do who are using those folks and then they're no longer able to practice?
So to be super clear, it's a property right if you are already a CAC 2 or a CAC 3 that did not have a bachelor's degree, you already have that credential. Even though it got transferred to a CAS, if you do not have the bachelor's degree and you don't meet the statutory requirements, you've already received the credential at the first place, so you're essentially grandfathered in to provide that level of care as a CAS, even if you don't have the bachelor's degree, right? So it's really about those folks that are currently working on, they were planning on becoming a CAC 2, they don't meet the bachelor's degree requirement, so what happens now? So DORA has said that those individuals have until April 1st to get their application in. You don't have to meet the bachelor's degree requirement in order to get your application in, as long as you get it in by April 1st. That's what they're calling this grandfathering process. So this is me speaking for DORA. So if you have specific things related to that, that needs to be DORA in the examiner's board. But that is the piece, is that is the workforce conundrum we're in, right? So it takes some time to go through all the classes to become a CAC 2, right? So it's those folks. We've also had essentially colleges call and say, well, we have people that graduate in May, and if this goes into effect April 1st, then what happens? Like, they're going to be short, right? They're going to be short on classes. They're not going to have their bachelor's degree by this time. So what happens then? Or maybe they're going through getting in an associate's degree, right? So they wouldn't meet the bachelor's degree requirement. I should have corrected myself there. So what happens there? So there are a lot of things that still need to get worked out with this. The real piece to this is DORA and how they enforce this article within their section of Colorado laws, right? So it's OBH gets a lot of these questions, and a lot of it is, we kind of know what they're doing now, but all of these nuanced questions, I mean, it has to be DORA that's the one answering those, because the April 1st is just kind of an arbitrary date. Our rules going in effect April 1st, that's ensuring that people meet the classes that they have to meet, right? Those classes are also dictated by statute. So our rules essentially just copy what it says in statute, saying you have to have these classes to be a technician or a specialist. So our rules don't do a whole ton for the program or change really anything because it's all laid out in statute. So really there's a big difference between what rules can do and what statute can do, right? So rules cannot change statute. So we're kind of stuck with what we got unless there's some sort of legislative change to the program. I've not heard that there's a plan to make any changes, especially because the bill just passed. But that doesn't mean that there aren't other entities working behind the scenes to try to get some things changed within the whole addiction counseling profession. So sorry, I don't have a ton of good information there, but yeah, it's one of those ones where we have a role, it's a relatively minor role. And yeah, it's one of those tough ones because it wasn't part of the sunset review process to make changes to the addiction counseling field. It was an amendment to 1206 kind of during the time of COVID. So I think it kind of snuck under a lot of the organizations that, I mean, are having concerns right now, which is really sad, right? Because the effect that this has on the expanding system is, could be pretty substantial. So. That's what I had.
Okay. Any other question, concern, things folks want to bring up?
So were we going to hear something about employment? I thought there were, is that next month?
Yeah, we're going to go ahead and do that next month. Yeah. Employment, and then we're going to talk about peer specialists in employment, and we're going to talk about peer specialists. I'm hoping just to get a lot of ideas from everybody. I'm really excited because it just seems like with the conversation that we've been having in the last couple months that we definitely need to be making some recommendations along the lines of getting some peer specialists everywhere if we can.
Mm-hmm. Okay. Well, Brian, you and Donda will get folks when you have it, maybe a link to how they can listen in to that meeting on the 9th if they wanted to.
Yep.
So that'll get sent out via email.
Yep. Yeah. So it'll be the link to the Joint Budget Committee. Yeah, through the General Assembly website. So yes, we'll get that out end of the week or early next week. So
okay,
you have it for the 9th. Yep. And like Aaliyah said, so then the next 2 months are talking specifically about recovery. So we'll have a presentation kind of about what recovery currently looks like in Colorado, and then kind of the same format over these last 2 months, which were treatment, and then the 2 months prior to that, which were prevention, and then recovery next. And so come with those ideas for recovery. I know that we'll have a lot of robust conversations, I'm sure.
Yeah.
Be nice to me.
Well, everyone will hopefully get some respite over their holiday season. So we'll meet again on the 7th of January. So if there's nothing else, then I hope everyone has a really happy holiday season, even under these sort of weird circumstances, and a happy new year. And as always, you're welcome to reach out to Julie or myself or Ryan if you have questions in the meantime. But otherwise, enjoy your extra 25 minutes this morning, and we'll see you next month.
Thank you.
Thanks, everyone.
Take care.
Take care, everyone.